So you have a 47-year-old gentleman presented to A&E department with severe left loin pain. CT scan KUB was done showing the following. Please look at the CT scan and comment on it.
So this is a CT scan reconstruction coronal film, non-contrast. I can see almost 1 centimeter or less proximal ureteric stone on the left side with mild hydronephrosis. I would like to see the rest of the imaging to rule out any other stones.
Okay, any further imaging you want to check?
So I would like to check the scout film to see the radiopacity of this stone.
Okay, the scout film shows no stones. What's your next step?
So I would arrange for X-ray KUB, because some stones can be shown in the X-ray rather than the scout film.
What is the percentage of that?
I'm not sure, maybe 10%.
Yeah, good. Okay.
Then this is regarding the scan. Then I would like to go and see the patient myself and assess him.
Very good. How would you assess the patient? Tell me, in regard to the history and physical examination.
So history-wise, I would like to see the onset and course of and duration of the pain. Was it associated with any fever or feeling unwell, vomiting, any previous history of similar pains? And also I would like to check if he has any previous history of kidney stones or urinary stones, any previous urological interventions, and his comorbidities and fitness for any surgeries. Also, I would like to check if he's on any regular medications.
Okay.
And family history for stone.
Very good. What about your physical examination?
My examination would focus on like general examination, check on the abdominal examination, back examination of the back and genitalia in the presence of chaperone. Yeah, and I'll check on if there is any flank tenderness or pain.
Okay, fine. So what investigation would you request for this gentleman?
So for this gentleman, I would like to arrange for urine tests, urine dip, and urine culture sensitivity if appropriate. I would also arrange for blood tests in the form of calcium, uric acid, full blood count, urea and electrolytes, and clotting profile.
Very good.
Okay. As well as I will arrange for some, yeah, he has already imaging, yeah.
Very good. So the patient has no pain so far. His eGFR is 79 ml per minute. No infection. What's your next step for this gentleman?
So I would like to know the size of the stone.
Okay, it's 6 millimeter stone.
6 millimeter proximal ureteric stone. So I would discuss with the patient the management options, mainly conservative management. I will explain to him that 6 millimeter stone in the proximal ureter has a possibility of 30 to 40% to pass spontaneously. So I would encourage him about conservative management.
Yeah.
And if he's happy with the plan and he has no absolute indication for the surgery, then we'll go for conservative management. So I wouldn't arrange for medical expulsive therapy, and I would send him home with safety netting advice to come back if there's any.
Why don't you want to proceed with MAT?
So as per the NICE guidelines, it's recommended for stones less than 1 centimeter in the distal ureter.
Okay.
So and it's controversial evidence anyway, so I wouldn't go for that.
Okay, fair enough. Right. What is the chance? You mentioned that already. What are the phases of renal deterioration with unilateral ureteric obstruction?
So there are 3 phases. First phase is from the start of the pain till 1.5 hour, so 1.5 hours. In this phase, there's increase in the intrarenal pressure and increase in the renal blood flow. Second phase, up to 5 hours, from 1.5 to 5 hours, where still the renal pressure is high, but the pelvic pressure is high, and renal blood flow is start to reduce. And the last phase, after 6 hours, the renal blood flow start to decrease. And this process is manipulated by or done by the prostaglandin effect.
Like, what's your follow-up plan for this gentleman?
So I would send him on with some painkillers and also arrange for scout film in 3 weeks and follow-up appointment in 4 weeks. And I will explain to him that if he has passed the stone, to catch it so we can send it for analysis.
So you said you're going to arrange for a scout film?
Sorry, plain X-ray
X-ray?
KUB. Yeah. So.
And this is provided that you can see the stone in the plain X-ray, obviously.
Yes, sure. So if it's not visualized, then I will arrange for CT KUB low dose.
Very good. What is the millisievert of the low dose CT KUB?
So 1 to 3 millisievert.
Is it? Okay, we'll talk about it anyway. Okay, what are the indication of shockwave lithotripsy in ureteric stones?
In ureteric stones, if the stone is less than 1 centimeter,
okay,
and proximal or anywhere in the ureter, as long as we can localize it. If there is no other contraindications for ESWL as well.
Very well. Okay. Right, you see a 67-year-old gentleman in your stone clinic. He came with a
Before you
recurrent...
start, because lots of people are complaining they can't log in. I didn't want to interrupt the discussion.
Oh, okay, sorry.
There's lots of people in the group, so if you can check, please, on the WhatsApp.
Fair enough.
Because I didn't want to interrupt because it was a good discussion.
No, that's fine. No, this is... Anyway, the case is done.
That's why I spoke. Thank you.
Now, let me see who's there. The link is valid. I don't know. Let's see. Let's wait for them. So until they come, let's comment on Ayman. Ayman, you did very well.
Thank you. I just forgot to mention the mimic calculator.
Yeah, I was going to tell you, you will get straight 7, but not 8, because you could mention the mimic trial.
Yeah.
And you could mention suspend trial for the medical expulsive therapy, as well as mimic trial.
Yeah.
Because both declined using the MET.
Yeah.
But you did mention the NICE guideline for that supports using it for these. So that's fine. But if you mention the mimic trial, definitely you will get a very high score. The only thing, so everything counts here. The way you talk is very good. You're fluent. I'm not sure how you move your hands and body language. I can't see you. That matters as well in the exam.
Yeah.
And you did comment on the CT scan very well. You mentioned the stone, then you mentioned what's proximal to the stone and what's distal to the stone. So you talked about the mild hydroureter. I would also mention a little bit, always comment on the perinephric area, a little bit of perinephric fat stranding.
Yeah.
And you did comment on the distal, what's distal to the stone, that you want to see the bladder, which is very good.
Yeah.
That's good. When I go to see the patient, A&E, always start with assessing the vital signs of the patient, because he might be septic, etc. So don't jump to the history straight away.
Just because you asked me specifically about the history, and that's why I want to answer.
Fine. That's you can argue that. I agree with you, but still, like, just keep it a habit.
Yeah.
You can also say, provided that he's vitally stable, I will take this. So that's very good. Nothing really. No mistakes. I think you did very well. Any comment, guys? Let's see the group. They're not.
So I have a question. So we have a 6 millimeter upper ureteric stone, and we're planning to treat this conservatively. But if we're gonna mention the what do we call it? Is it the trial? Sorry, I forgot the name. The mimic study.
Yeah.
And according to the table, 6 millimeter upper ureter, it's 24% to pass by itself. Are we
Yeah.
still doing this, or shall we just offer a ureteroscopy for this?
No, still. Up to you can give it a try. Since there is no pain, no deterioration of the kidney function, you can go conservatively. Also, bear in mind that it's not easy to calculate the passage rate. You need to use the online, because mimic trials stratify these stones based on the size and based on the location, and if you combine both, it's not easy to calculate it. So if you do the online calculation, maybe it's different from the number you mentioned. But anyway, if you think 6 millimeter stone is passable stone, even if it's around 30% is possible. It's a good percentage, I would say. I would give it a try with 6 millimeter stone. Maybe it's 7 or 8. Well, it's debatable, but I would definitely go conservatively with 6 millimeter stone. Guys, I think we need to do something about this link. Wait a second. Any suggestions? Should we log off and give you I'll give you another link, maybe?
Yes. Yeah.
Okay, so I'll leave now. I'll give you another link. Fine. So it was proximal 6 millimeter ureteric stone. It was managed conservatively because there's no pain or deterioration of the kidney function, no infection or sepsis. So Ayman decided to manage this case conservatively. He requested a scout film first to make sure that it's visible, so he can request a plain X-ray in 4 weeks. Obviously, there are too many stuff we discussed in the case, but we will go through this again, hopefully in other cases. So we don't really need to repeat this case. It was a straightforward case. In these studies, so always remember, guys, in ureteric stones, people are still coming. Give me a second. Okay, in ureteric stones, there are 3 scenarios, mainly 3 scenarios. Either ureteric stone with sepsis, so you drain, either with a stent or nephrostomy. So usually you go for nephrostomy to mention the trials, Mokmalji trial, etc. Or there is ureteric stone, which is a very big stone, like 8 millimeter, and it's not passing, obviously, but it causes no pain, no deterioration of the kidney function, and no sepsis. So the question is, will I manage this conservatively or proceed with surgery? So obviously this stone is not going to pass. Very unlikely if it's 9 millimeter or 1 centimeter stone. So in this case, you operate within 48 hours. That's the second scenario. Sorry, people are still coming. Okay. The third scenario is if the patient has small stone with that could be managed conservatively. So mainly three scenarios in the ureter. Okay, fine. Let's take another case. All this will be repeated, don't worry. So who's next?
I can't try Rakan.
Okay, who's that? Just mention your name. I don't see anyone. Aldani. Okay, Aldani. Very good. So don't look at the screen. So you have, let me just put the timer for you. Okay. So you have a 67-year-old gentleman in your stone clinic. He came with recurrent UTI and loin pain. What important points in the history and examination would you consider?
Okay, so I will see this gentleman in my clinic. I'll take a full history about his symptoms. I will analyze the symptoms, the loin pain, and the recurrent UTI. For the loin pain, I will take a history about the onset, course, duration, severity of the pain, and if he's taken any pain medication for that, and is the pain referred to certain area. Also, is it associated with any blood in urine, and also for the recurrent UTI, I will take I will take a history about how frequently he get the UTI, and when was the last attack, any medication, any antibiotic received, any documented culture with the GP, any associated symptom red flag symptoms, including blood in urine, or any difficulty in passing urine, any associated lower urinary tract symptoms. This is for the history. for the examination. I will make sure the patient.
Wouldn't you consider other like diseases, comorbidity that could contribute to stone diseases?
Yeah, sure. Yeah, sure.
Okay.
I will go through the history, including the medical history, any associated comorbidities, any medical background, past history, any past history of any stone disease, any family history of any stone disease, any previous urological procedures, any has he managed to pass stone before or not, pass
Right.
stone basal or not? Yeah.
Okay. Yeah. Go ahead.
Okay. Then I will, regarding the examination, so I will do general examination, local examination. I will focus mainly in the local examination, on the abdominal examination. Regarding the general examination first, I will take the body temperature, the blood pressure, and I will check the vital signs. Regarding the local examination, we examine the abdomen by loin examination, by manual examination. I will make sure the bladder is not full. I will have a look in the external genitalia with the chaperone, and then I will do a dipstick for him.
Okay, fine. What investigation would you request?
Yes, so for this patient, I would request bloods, which include renal function test and full blood count, bleeding profile, and MCU for him. Before I will do the dipstick, and if it is positive, I will do MCU. Ultrasound of the kidney. I will request ultrasound of the kidney.
So this is the ultrasound. You can look at the image. Take me through it.
So this is grayscale of the kidney, showing there is a hydronephrosis, moderate hydronephrosis and dilatation of the pelvic calcial system, and there is radio-opaque shadow in the junction between the kidney and the pelvis and the ureter. And there's aquastic shadow behind the posterior aquastic shadow. So most likely pelvic junction or proximal. I would consider it pelvic junction stone causing hydronephrosis of the kidney.
Okay, it's right kidney, right?
This is the right kidney. Okay, so I'll make sure that I
see here.
Yeah, the left kidney as well, and the bladder, and yeah.
Okay, so you have this patient now with upper ureteric PUJ stone. It looks like it's a sizable stone, I guess. So what's your next step here? The patient is in your clinic.
So I will counsel the patient first that the ultrasound showing there is a stone in the kidney causing hydronephrosis, and we will require a CT scan because the sensitivity of the CT scan is more than the ultrasound for the size and for assessment of the anatomy. So I will request a CT-QB scan for him. I'll try to expedite this for him to make a plan for the treatment. Okay,
this is your CT scan. Take me through it.
So this is CT scan abdomen pelvis showing a transverse film and showing the stone in the right ureter, radiopaque shadow or hyperintense shadow in the right ureter, and this is matching with the previous ultrasound image, which showed the ultrasound image which showed stone in the proximal ureter.
Okay, so is this CT with contrast or with no contrast?
No, this is CT without contrast. Also, I can see there is without.
Looks like contrast, kind of.
Yes, with contrast, correct.
Okay, fine. So what about the other film here?
So I would like to see the coronal film and assess the other kidney. And also I would like to get some information about this kidney, if this kidney is taking contrast or not. And
why do you want to do that? Why do you want to do that?
To make sure this.
Do you usually request a CT with contrast?
No, I don't request CT. I don't request CT with contrast for stone.
Fine.
Yeah.
So what about this film down here?
This is plain X-ray.
Okay.
This plain X-ray abdomen pelvis and showing radiopaque shadow in the left renal region. And it looks like a radiopaque stone, comparing it to the bone density.
So is there any? So it's on the left side, or is it in the correct side?
In the left side, yeah. In the left side, yes.
So is it the same patient, or this is?
Yes, it is the same patient.
Okay, explain to me.
But this is no, it's not the same patient because this is in the renal region. However, previously the ultrasound and the CT showed it is in the
You can tell this
proximal
is
ureter. Yeah,
well, no, it's
this is
PUJ
renal.
stone. You can could be PUJ stone still. Like you can
Um,
tell. So I'm talking about the site, right or left. This is
this
what's the site of the stone?
So there is no mark to see the relative left, but it seems to be if this it's the left
Okay.
side. Yeah.
Fine. So the patient has plain X-ray which shows radiopaque stone. What's your next step here?
So I would like to get some information about the stone after making the history from the patient about assess his fitness for operation and he comorbidities. I would like to get some information about the stone, the size, and
Well, it's 1 centimeter, 1 centimeter stone.
1 centimeter in the PUJ, correct?
Yeah.
And the degree of the hydronephrosis and severity of the patient's symptoms. If the patient has severe symptoms and complaining and he has been refractory to analgesia, I would consider stenting this patient before further intervention. If the patient's symptoms are stable and there is no obstruction.
Yeah.
So,
well, there is an obstruction.
Exactly.
There's always an obstruction in stones, even if it's partial.
Sure. So, as I mentioned, based on the symptoms of the patient, so if the patient is asymptomatic and we can proceed for further treatment, which will be here, we have the option between shockwave lithotripsy and flexible ureteroscopy. However, if the patient is having symptoms and so we have to.
So tell me, what would you do? Tell me, what would you do? This is your patient in your clinic.
Okay, fine. So for this case, I can see there is a moderate degree of hydronephrosis. So I would consider stenting the patient before any further procedure.
So you will take this patient from the clinic. You will admit him to stent him.
If the patient is stable and there is no symptoms and he doesn't have any issue because of symptom complaint, current UTI as well. So there might be possibility, yeah, and based on the bloods, I will make a plan. If the patient is stable and there is no symptoms and this hydronephrosis going for a time, I would consider definitive surgery or definitive procedure for him.
Okay, fine. How do you think you did?
It's a case of that debatable, like that's why I get confused. So you
I can tell at the
I'm
end,
just get confused. I get a lot of confusion from the clinical practice and from the scenarios.
True, from I got your point. So you started with good history, but you missed. So if you are asked about history, you need to mention good history.
Sure.
If you are not asked about history, fine, you can skip. And you will see the examiner actually moving you for like skipping. But if you are asked about history, you need to you tell the patient, the examiner, about good history. If you are asked about history, which is very common in female urology, in pediatric urology, he will tell you, tell me about what history would you take, for example. In stones, it's unlikely, but since I asked you about the history, you need to tell me very good history. So you didn't ask, for example, about upper UTI, which is very important. Because recurrent pyelonephrosis is an indication of intervention, even for small stone.
Sure.
That's a guideline. So it is important to ask about upper UTI. You did ask about the onset, course, duration of stones, recurrent UTI. That's very good. It is very important if we're dealing with stones to ask about the diseases, any comorbidity that could cause disease. The patient might have hyperparathyroidism. He might have gout disease. He might have hypokalemia, chronic or whatsoever. So it is important to ask about diseases. Very important. About bowel symptoms. Very important, because bowel problem could lead to stone formation. Medication. Very important.
Yes.
All these stuff you need to be asking about if you are asking about the history. Examination. There isn't much, but you mentioned what's needed to be asked. Really, tenderness in the loin, to exclude signs of pyelonephrosis, etc. That's really important. Examination of the genitalia is important for you if you want to proceed with surgery, for example. So you need to know if you don't want surprises intraoperative, like significant fibrosis or whatsoever. So that's really important. Investigation, while you mentioned everything correctly, well done. CT KUB, you were given CT with contrast, so you sorry, you mentioned ultrasound. So grayscale ultrasound showing hyperechoic. You said radio opaque. Probably this is just it's a common mistake, but remember the radio opaque is wrong. This is hyperechoic lesion with shadow indicating stone in the PJ. I need to see the other kidney. I need to see the bladder. I need to see the rest of the imaging.
Sure.
Which you mentioned it almost correct, but remember the radio opaque shadow, it's not radio opaque shadow. Then you requested a CT. I gave you a CT with contrast. You need to ask me, I need to see the CT with no contrast to have a better comment. Then I would show you the picture with no contrast. And this, you mentioned hyper intense, it's hyper dense. The hyper intense of the MRI scan, remember that. That's important. So it's hyper dense lesion on the proximal ureter, almost on the PJ. So this is a film. This is a scout film, even plain X-ray in posterior view. So usually if you do anteroposterior view, right is left and left is right, but it's posterior view, left is left and right is right. So this is the same patient with the same stone, but the right is right. So this is this is the same patient. This question came in the MUs, East Midland BOWS. So they want you to know that sometimes plain X-rays, the scout film, most of the time is posterior view. So most of the time the right is right and the left is left, like DMSA scan, for example. So remember that. Don't say this is for another patient, so that will fail you. Be careful. So management option, you kept, so you were doing well until you started talking about the management. So here you're probably going to fail because I want you to mention to me, what are you going to do in your clinic? I want to do 1, 2, 3, 4. So I want to, so this patient has 1 centimeter stone. My option is to go for shockwave lithotripsy since it's radio opaque. Full stop. I'm done. You kept just rotating around the same idea. So you don't want to mention, because I know you're confusion. You're confused because there's hydronephrosis. So you don't really know whether you want to stent or you go for elective surgery. Is that correct? Right. Exactly. I know this confusion. So you kept rotating around. So even if you get similar questions in the exam, you need to be precise and just do what you want to do and defend it. If you do the way you did, you will fail the station 100%. There is no doubt. You got my point? So you say, well, I will do, well, this is hydronephrosis, but it's not progressive hydronephrosis. There is no signs of infection. I will put him on elective surgery in the next week. I will try to squeeze him in my list to do the procedure. Shockwave lithotripsy, yeah. You can do it within 48 hours, obviously, as per the guidelines.
The issue is that, Rakan, this is against any practice.
No,
this is against
why?
my practice, even. My practice, usually we stand the patient and do
flexible. No, you don't
microscopy.
need to stand the patient.
Exactly. No. So I agree for that, but I mean the.
You know what? Even if your practice is like this, if you can speak it up and defend it in the exam, but you just need to mention something. If you keep going around the two options without mentioning some, that's the worst thing.
Yeah.
But if you say, you know what, I'm gonna stent this patient, the examiner will say, why would you stent? Well, I'm not happy with this hydronephrosis. I would be over suspicious. I will stent this patient. I will do, however, I will try to put him on a shockwave lithotripsy list in the next 2 days. But I mean, you can discuss it.
Yes,
I wouldn't go with, obviously, I'm not going to discuss, do stenting for this guy. But you know what I mean. So don't keep, you need to mention something and defend it. Otherwise, you will fail the station.
Sure.
Very good. So what is the indication of shockwave lithotripsy for ureteric stones? Nice guideline.
So the nice guidelines say if it's the ureteric stone, if it's less than 1 centimeter.
Yes, in any part of the.
There is no signs of obstruction, no sign of infection. Yeah, and yes.
Okay, remember something. The obstruction is little bit debatable because all stones will cause obstruction. So if the obstruction, because for this case, you might say, well, he's an obstructed system. Well, if there's no progressive dilatation, like you did ultrasound and followed by CT, and you don't see any progressive dilatation, there's no fat stranding, the patient is symptomless, there's no deterioration of the kidney, you can support shockwave lithotripsy, because all stones will have, most of the, 70% will have obstructive element, like hydroureter or whatsoever. So you can still do shockwave lithotripsy, provided none of what I mentioned is available.
Can I just ask Rakan something?
Go ahead. Yeah.
In this case, the patient is having loin pain.
Yeah.
This is on
so this is that's a good point. This is recurrent loin pain. He came to the clinic electively, not to the emergency. So definitely he's going to come to the clinic because of pain. That's not the pain that will bring him to the A&E and I'll go on stent him. If the pain is severe, obviously he will go to A&E department, or if he develops severe pain in the clinic, he will go to for stenting or whatsoever. The point is, we don't really need to reinvent the wheel in the exam. These are very common cases. If he comes to your clinic, most of the time, this is the case. Like it will go electively, most of the time. Obviously, they could change a lot. Like you might discover that he's septic in the clinic or whatsoever. But I mean, so these are very strict cases in the exam. Patient come to the clinic, so he will go electively. Patient come to A&E, so he will go with stenting and dredge, etc. Okay, but again, you go with the curve. If you think the examiner is like taking you toward more emergency kind of scenario, fine, you shift with them. You are able to do that, obviously. But in this scenario, there isn't any, because pain, recurrent pain, so what? Like it's recurrent pain.
Okay, so Rakan, I have a question. So he came to the clinic with recurrent UTI. Do we need to mention that we need to do metabolic workup for him or not? Because I believe this is one of the indications to do.
Like recurrent UTI?
Yeah.
Yeah, but you can talk about metabolic evaluation before you treat the stone.
Definitely, yeah.
Because it will give you a false reading anyway. So I wouldn't mention that really in that scenario. Unless the examiner asks me, like, but even if he had recurrent. So what is the indication of metabolic recurrent UTI?
Because this is what I know from where I studied. It says recurrent UTI family history. If it's Staghorn, if there is bilateral.
Actually, anything is indication for metabolic. There are a big list. Yeah. But I wouldn't mention that really in this scenario. Before I treat the stone, because the scenario is built on how you treat the stone and shockwave and the type of the shockwaves.
Yeah.
Tell me.
It's not the recurrent infection. If a patient recurrent infection and we diagnose from stone, then we can, if it is turbate stone, it's an indication for metabolic, not the recurrent UTI by itself.
That's my point. Very good. Who's that? Mu'taz?
Mu'taz.
Yeah, I think you are right. Double check, guys. Because recurrent UTI by itself is not a back, but if it is a strovite stone, obviously that's an indication. Strovite, uric acid, phosphate, so they are indication for metabolic PUS. But recurrent UTI is not by itself, is not an indication for metabolic evaluation. Just check on that. Just check. Maybe I'm wrong.
No, definitely right.
But very good, guys. Very good.
A question, please.
Yeah, go ahead.
So this patient presents with loin pain and recurrent UTI. So we think most of the cases we by this scenario might suspecting about Staghorn stone. Okay. So is it wrong if I ask it after kidney function assessment a CT urogram, or is it wrong?
Why do you want a CT even? Well, even with a CT, with a no, of course not. I wouldn't do CT urogram.
So
why did you do? You mean because you had an ultrasound? What's your point? The patient had an ultrasound, right? You want to request a CTU even before the ultrasound, right?
Yeah. So
no. I would go. You might go with CT without an ultrasound. This is acceptable. That's fine. You don't really need to go with an ultrasound. You can jump to the CT, but I wouldn't do CTU. No, of course not, because that will probably, you might fail the station. because he will tell you, why do you want CTU? Yeah, why? Like, you're gonna mask the stone even.
Okay.
It is true that the CTU will come with CTQB, but since you didn't mention, you said CTU, he will assume that you don't know anything about it. You know what I mean?
I got it.
Maybe Rakan.
Yeah.
Once we confirm, for example, calical stone or staghorn stone,
yeah,
some endourologists would request CT urogram for detailed intrarenal anatomy.
Fine, you can do that.
But
I know.
Depends on the case.
Of course, yeah, I know some people do that, but that you can, if you are a stone surgeon and you did it all the time, yeah, fine, say that, but I wouldn't say it, because I think it's overkilling, unless the case is the anatomy is a little bit obscured or something. But I would do DMSA scan. Obviously, the examiner is waiting for the DMSA, he's not waiting for CTU. I'm not saying CTU might be correct, but it will mean nothing for the examiner. He wants you to say DMSA for staghorn stone.
I have a comment just
go ahead.
In the history. I think we should ask about the drinking habits, fluid habits. We should ask about the profession.
Yeah.
And to ask specifically of stone history, previous stone. And to ask about history stones.
He did ask about that.
Just to mention.
Yeah, he mentioned that, but yeah, so again, so you need to go through the history very well, but it's unlikely to be asked like detailed history in the stone disease. But if you're asked, yeah, you need to go through all that. It's all in the notes. You can find it. I'll send it to you.
Just Rakan, this case may be confusing between recurrent UTI and loin pain, because we are today in a stone session.
Yeah.
So that's why we will speak about it. So, but imagine if it's this case in the exam and you know what's that. So you will be confused between recurrent UTI and the age of the patient, the lots, and the loin pain.
No, I don't know. Explain more.
I don't agree.
I mean the age of the patient, recurrent UTI, loin pain. You will be confused between you want to ask specific for stones, or you will ask about the recurrent UTI, or you will ask about his voiding symptoms as well. You need to cover all this in the history,
of course,
because you're not sure this is stone or not.
Yeah, true. Yeah, I got your point now. I got your point. That's true. That's true, especially that the stone comes with UTI. Right?
Sure.
I mean, the stations, right? Just remind me.
Yeah, maybe.
Yeah, but
maybe this is infravesical obstruction, and he just have hydronephrosis, and he has recurrent from the prostate. So that's why I don't go in deep for the stone history. I want to cover all the history.
Okay, fine. So yeah, let me answer this, Zulfi, please. So for your question, in regard to your question, number one is it's unlikely really to be asked about history in the stone disease. However, you will be told that you are doing stone station or UTI
that's
station.
Nice.
Yeah, you will be told you are doing stone station, so it's unlikely to shift that way.
This is easy now.
Yeah, exactly. So tell me, Mr. Zulfi.
So this is interesting, I think. So very good, pointing towards the loin pain and recurrent UTI. Or we should at once think of this. You know, we're going towards a staghorn calculus. I think this is very interesting.
Like just to start thinking of staghorn, you mean?
Start thinking of staghorn calculus also. You know.
Well, you can, but you need to follow ABC. Like after loin pain in the clinic, we always request an ultrasound or CT. Sometimes we jump to CT. That's fair enough. Then you go with whatever the scenario takes you to. You might find bilateral stones. You might find a tumor, whatsoever. You might find a tumor and a stone. If it's a complicated case, you might find anything in the exam. So stick to the. So none of the questions are difficult. All questions are easy if you go to the basic. Whatever you find, just go with 1, 2, 3, 4, and you will reach the goal. Don't get surprised or scared or feared if there's something weird. You go for TURP and accidentally you find a very huge stone. So what? So I just deal with the stone, finish the stone, and then bring the patient like whatsoever. So don't, because you will find scenarios in the definitely difficult scenarios in the exam. They are not difficult. You just need to calm down and just answer.
I think the dilemma in this scenario, the TRP and the stone, is the consent. Would you proceed without consenting, or?
What do you mean?
So if you are consenting patient for TRP and you found big bladder stone, would you do the stone without consenting?
Yeah, that's a good question. You tell me, how would you answer it?
Yeah, so personally, I would deal with the stone. Then I will inform the patient after the procedure. And if it's like big stone, took a long time, a lot of time, then I will just finish the stone and postpone the TRP. If it's manageable and small stone, then I would proceed for TRP afterwards.
Yeah, this is what I would do exactly. This is what you should answer in the exam. It came in the exam, didn't come to me, but it was a scenario in our exam.
Yeah.
And this is like, frankly, this is unlikely scenario, obviously, especially in the UK. But it's like.
And one last thing, Rakan, if you don't mind, would you speak to this patient about only shockwave, or you would give him alternative? Because always in stone we give alternatives. Like we have the option of shockwave, we have the option of, or you will just say shockwave and that's it.
No, I will go with a nice guideline, which suggests shockwave lithotripsy as a first option.
Sure.
Then the flexible ureteroscopy or whatsoever.
Sure. I agree.
Okay,
that's
beautiful.
Would you bring to discussion PCNL since it is 1 centimeter stone?
No. 1 centimeter? No, I wouldn't.
In the ureter?
No, in the ureter, do you mean, no, he means like in the upper, in the PG, you can go from the upper calyx and get it. Is that correct? No, nobody does that for 1 centimeter, so that would be, no. If you say that, probably you fail the station. Because don't say, and even if you do it, if you did it once with like a consultant or so, but obviously if 1 centimeter, that's overkilling anyway. But always remember in the exam, don't bring the extremes to the table. Just be normal. You can show your knowledge by giving more studies, but don't give our weird like experience or something weird. You've done, don't do that. You will fail the station.
So we will give him alternatives of URS versus ESWL in this case, or I will tell him I will do this, but I will still give the patient option the other alternative.
Well, I would tell him. So the exam is basically studying or examining your performance. So I would say in this case, I will offer this patient the shockwave lithotripsy because this is as per NICE guideline. However, the EU guidelines suggesting other option, which is flexible ureteroscopy. But that I wouldn't like just do what you normally do in your practice, provided that it goes with the NICE guideline. But don't worry, even if you mention something, so you might mention, for example, flexible ureteroscopy. He's not gonna fail you. He will try to prompt you probably. Well, is that a NICE guideline? Do you do this in your practice? And also remember something. You need to be a bit smart because he's showing you already opaque stone, so you know that this scenario is going towards shockwave lithotripsy. Why do you shift it? You know what I mean?
To follow his cues, you mean?
Say that again.
You want me to follow the cues he's offering to guide?
Yeah, of course. Yeah, definitely. The scenario offers you many cues, so just use it. Don't go. But even if you say I'll go with ureteroscopy, flexible ureteroscopy, definitely he's not going to fail you, but he might not be happy with your answer. Okay, happy guys?
Good. Yeah. Can I ask a quick question, please?
Yeah, go ahead.
If a candidate says, I would offer both options, the shockwave and the laser for the patient, and see if the easiest facility in my trust or the nearest date in my trust. Like let's say if they got a date for a shockwave next week, or you've got a date for ureteroscopy tomorrow or something, would that be a good answer?
So you're asking me personally, right?
Yeah, I mean, if you are
no, I wouldn't. I didn't think this case is for shockwave lithotripsy, really. But even if you say that, if I'm the examiner, I would say correct. Yeah, what would you do in your practice? You will say what you do because both are correct, really. There is no mistake in this. Yani both answers are correct. But I would go, if I'm the examinee, the trainee, I would go with obviously shock wave. I know this case; it comes all the time in the exam. I was trained to do this, so I wouldn't shift my answer. But I know because you haven't done the exam or so you are trying to build many scenarios in your head. Maybe something else comes, but it's okay if you do it in your practice and it's not a major mistake. Just say it's not a big deal, provided that you know what the NICE guideline says. So you, from now until the exam, just read the NICE guideline. It's just not too much, really.
Sorry, Rakan, the last question in the previous station was what are the types you use in your trust?
I didn't want to go through this because we're going to take it in the technology.
Okay, yeah.
Like we can electromagnetic, we don't need to do that now.
Okay, yeah.
But we're going to take it in the, definitely in the technology. That's a very important question. You all know that, right?
Is there any supporting study for in this scenario that I can mention?
In this scenario, okay, yeah, there is always studies. Let's see.
So is this proximal ureteric stone or renal pelvis stone?
No, this is this is PUJ stone.
So the mimic frame, I believe,
No, mimic is about spontaneous. It's about spontaneous message.
There is a TISO trial which compared ESWL to.
I would think about
yours.
Yeah. There is also many like you can use that. You use the NICE guideline as well to support your treatment. That's enough. You don't need to do. If you mention NICE guideline, that will support your. That will give you a boost mark as well.
Yeah.
So the most important thing in the exam, guys, is not to mention very stupid thing. Yeah. Otherwise, you will go easy. And don't miss easy questions. Like, for example, if they ask you about the bladder diary and you don't answer, that's fail. You failed the station, even if you do whatever. IPS score, if you... The questions are not always hard. Most of the questions are very easy. And you build up with these questions to go to the extreme. But don't miss easy questions and don't say something really extreme. And you will pass the exam. Okay, who's next?
I'm happy to take this one if you don't mind, Rakan.
Yeah,
I'm Peter.
What's your name, sorry?
Peter.
Peter, okay, go ahead, Peter, go ahead. Don't look at the screen, please.
Okay.
You have a 47-year-old lady with recurrent severe loin pain and recurrent UTI. What investigations would you request for this lady?
So I would start with a urine dip to check for blood leukocytes and nitrites, and also check the pH. Very low pH, less than 5.8 might suggest uric acid stones. More than 8.3 might suggest struvite stone. If it's nitrite positive, I would send that for MSU. For the bloods, I would do UNEs, calcium and urate and phosphate levels. I would also check CRB and white blood cells. I would check clotting if I'm planning for any surgical procedures. Scan, I would request a CT KUB and a plain CT KUB to start with and take it from there.
Okay, very good. So the blood shows no abnormalities. Calcium is normal, uric acid is normal. MSU shows positive for proteus infection. You can look at the screen. Take me through the CT.
All right, so that's a coronal section of a CT KUB showing a right-sided staghorn stone occupying most of the calyces with apparently normal-looking contralateral kidney.
Okay, anything else you want to comment on?
I would like to see the film down to the bladder, to be honest.
Okay, very good. Bladder is normal. What's your next step for this lady?
So I would counsel the patient about the CT scan finding and request a DMSA scan.
Why do you want to do DMSA scan for this lady?
Because it's a staghorn stone, so I would assess the split function of that kidney and also the function of the contralateral kidney before planning for any intervention.
Okay, why with staghorn stone you would assess the DMSA? Like, what's the reason behind that? Like, what if you have a big stone here, but it's not staghorn stone? Would you still do, or multiple stones, let's say, would you still do DMSA?
With a staghorn stone, I would assess a DMSA scan because there might be no residual function in that kidney. So
Okay.
before planning for a BCNL, it won't be reasonable. If there is no much function left, I would plan for nephrectomy at that point.
Fair enough. Okay. So this is the DMSA scan, Peter. Can you take me through it? Let me make it bigger for you, maybe. So this view is this view is posterior anterior view, is it?
Yes.
It says okay. So which means left is left and right is right.
And right is right, yeah.
Okay. So just comment on the DMSA scan.
So I haven't studied that part of technology yet, to be honest.
No, that's fine. You don't need to just comment. Just tell like it. So what is the split function here of the right and left? You can look down.
Yeah, yeah. So just showing that split function of the right side is 48% and left side is 52%.
Okay. So it's equal function. So it's almost
equal one. Yeah.
Okay, so fine. I'm not going to ask you about the DMSA scan for how it functions because you haven't studied it. So tell me about the pathophysiology of staghorn stone.
So staghorn stone happen because of usually urease producing organism infection, which examples are Proteus klebsiella or Staph aureus or ureaplasma. So this urease enzyme can split urea. Can split urea to CO2 and ammonia, and then ammonia can combine with water, which gives NH4 plus hydroxyl OH. Hydroxyl will make the urine alkaline, and that's how the stone would form in usually pH more than 8.3.
Very good. So what's the option for this lady?
All right. So given if she's fit enough after assessing her comorbidities and fitness, and given there is good function of the right kidney, I would counsel her about BCNL, percutaneous nephrolysotomy. So there is patient factors which has performance status, comorbidities, and also the stone factors, which is size of the stone, location, and the DMSA scan, which we have done.
Okay, how would you counsel her on that?
All right, so I would start using the BAUS information leaflet, discussing the indication, benefits and side effects of the procedure. So indication in this case, it's the size of the stone, if more than 2 centimeter. Benefits to get rid of the stone, maybe in one go or may need a staged procedure.
Okay.
Common side effects, she would expect blood coming from the nephrostomy tube afterwards for a few days. Also, there will be a catheter, can be taken out next day.
What do you mean catheter?
A urethral catheter.
Okay.
Other complication or side effects from the procedures, access related, which is failed access or multiple puncture, which is about or injury to surrounding structure like the colon or
can you take me through the steps
of the BCNL?
Yeah.
So the position is usually supine. I don't remember the name of the position. It's I can't remember the name of it, but usually we will start with dilating the system, going with retrograde access, urethral catheter, doing a retrograde study and injecting saline, and then we'll do the puncture, a standard BCNL 24 to 30 French.
Where do you do the puncture?
It's usually the lower posterior calyx.
Okay, nice. fine.
Then I would do the
Yeah,
stone
go ahead.
with lysotrips, pneumatic or ultrasound lysotrips here. Take the fragments out and usually leave an nephrostomy tube.
And
afterwards.
How do you dilate the tract?
So I would dilate the tract with balloon dilatation, 18 millimeter mercury. 18 millimeter mercury.
Is it millimeter mercury?
Water.
Okay, fine. Fine, you're doing very well so far. So what's if this patient is a bit frail, or if she's not happy with doing anything at this stage, what's your saying on that?
So I would say there is staghorn stones usually need to be treated as there is a high risk of mortality and morbidity, leaving it with no treatment. There is multiple studies on that. There is all the studies like Blandy and Singh, which found that 28% of mortality compared to 7% of mortality if had an intervention. There, I can offer here chronic antibiotic prophylaxis suppression, along with carbonic anhydrase inhibitors.
What is a carbonic anhydrase inhibitor?
Sorry, acetohydroxamic acid. I just got confused.
Okay, we'll talk about it. Fine. Okay, how do you think? It's 2 seconds left. How do you think you did?
Not too bad.
Okay, fair enough. So the question started with investigation. Would you request for this lady with recurrent UTI and loin pain? You started with MSU. Beautiful, well done. You started with dip, actually. I wouldn't go for dip. I'll go with MSU again straight away. Since I suspect infection, you don't really need to go for dip. If I don't expect infection, like a patient coming to my clinic with no problem whatsoever, I go for dip. But since I'm expecting infection, I would go for MSU straight away with the recurrent infection. That's number one. But else, you did very well. You mentioned something about the potential hydrogen of the urine. So you said if it's low pH, it will develop acidic stone like uric acid, and if it's high pH, it will develop struvite stone, right?
Yeah.
So that's partially correct. So struvite stone, remember, struvite stone is an infectious stone. Even with your alkaline urine, you don't develop infectious stones. If I make your urine alkaline now, would you develop? Say that again.
With alkaline urine, phosphate stone.
Phosphate, exactly, phosphate stone. So that's a very common mistake. So with alkaline urine, we develop phosphate stone, not struvite stone. Okay. But if we get urease infection, obviously urease releasing organism, in that case you develop struvite stone. But that's good anyway. So you request a CT scan with no contrast, and you commented on the CT scan very well. You are a bit slow. You need to be a little bit faster. More confidence, because all the pieces of information you mentioned are correct, but you need to be a bit faster and a little bit more confident. And I can't see how you're reacting with your hands and body habit. That's important as well. You need to show the examiner that you're a consultant, day one consultant. If you are hesitant, that's a big deal. Number two is, when I ask you a question that you don't know, don't stay silent. That you will lose time. You will lose confidence, and you will lose the confidence of the examiner on you as well. Either you say, okay, can we skip the question to the next question, or you try to find an answer somehow. Okay, but don't stay silent. That's a very big drop. Through the CT scan, you mentioned it perfectly well. There is no comment on it. Well done. What's the next step after the CT? You said DMSA scan. You commented on it. Yeah, you mentioned the percentage, which is fine. The pathophysiology was beautiful. Well done. Treatment options. You went through the PCNL, but you didn't give me a very good counseling for the patient, really. I wasn't convinced. If I'm the patient, I wouldn't be happy with your counseling. You need to be very precise in what's happening. You need to tell the patients what are the possible, no, I would say complications. You didn't mention it. You didn't mention the procedure steps very well, but they are correct overall. You wouldn't lose too much mark, but you need to be more precise in certain steps. So first of all, you need to mention that I will bring the patient to my urology clinic or stone clinic after discussing this case in the MDT meeting. Always mention the stone MDT meeting. That's important. Especially with staghorn stone. Now, for example, in Leicester, we do all stones in MDT, even if it's 1 millimeter stone. The reason for this is because we don't want any patient to fall away from our umbrella, to get lost. So all stones go through the MDT, and I think this is a practice now everywhere. So not to mention staghorn. So through MDT meeting, I'll meet this patient in my clinic, considering the bowel information, leave to update the patient on possible complication, alternative option, etc. You know all about that. When we talk about the complications, I always, in my practice, what I do is I always start with what the patient would expect after the surgery. Straight away. So I will tell the patient, you will be moved to normal ward. You might see a tube coming from your kidney. That's the nephrostomy tube. We might remove it the next day, and you will have most likely a catheter, which will be taken once you are mobilizing. Right. And intraoperatively, there are possible complications. There are complications of the axis, complications of stones, complications of infections. Complication of, you don't need to enumerate that to the examiner. It would be like ST level if you do that. I would say during the axis, I might experience a possibility of injuring of any of the surrounding structure, which is less than 2%. Also, there is a risk that I couldn't really access the kidney in less than 2% of the cases. And also, I might need multiple accesses in order to finish all the stones. And if after the access, there is always risk of residual stone, especially with staghorn stone, is up to 5% because it's a big stone. And also there's a risk of multiple procedure. There is a risk of recurrence of the stone, 10% in 1 year and 50% in 10 years. And then risk of infection, risk of sepsis, risk of injury of major blood vessels, etc. You can go through the notes. So that's really important. So you need to be confident, you need to be fast, you need to be, you shouldn't be silent. Okay.
Okay, that's first station to practice. That's why
I know. But you did very well. You did. It's your first. You did very well. I have no doubt in your piece of information here. You did very good. It's just the confidence.
Yeah. Can I ask just a question about the DEMSA scan, because I said I haven't studied it.
Yeah.
So is it enough just to say like it's showing that the split function is like 43 and 57?
That's enough. That's enough for the stone session, obviously.
Okay.
But obviously you need to study the dimeric carboxylic acid scan for the technology station. It's a very common question.
If you don't mind, please, can you comment it in few words, please, if you don't mind?
Well, you mean DMSA scan?
Yes, can you comment on this?
Ideal comment more than what he said. This is a DMSA nuclear scan. It shows almost equal uptake in both kidneys. I can see the posterior and the anterior view, and both have the same uptake with almost similar split function. Nothing really major about DMSA scan. Even in the technology station, there isn't much you say about DMSA scan as a scan itself. It's not like the MAG3, etc.
Yeah.
So nothing really concerning about it, really.
I would just add there is good uptake here, suggesting good renal function, because the uptake might be equal but hazy. So this suggests low renal
function.
Good.
Yeah, good job. True, Ayman. Okay, can we leave a staghorn stone untreated? That's a debate. That's a big. That's an important question. I asked you a question. Why do you request a DMSA scan, right?
Yeah.
The reason why we request a DMSA scan is because staghorn stone is a growing infectious stone. This is the only reason. Infection kills tissue with time. That's why you can't leave a staghorn stone. We'll talk about leaving it because there are some studies supporting that now. So I can't leave a staghorn stone, but I can leave a 2 centimeter stone in the lower pole of the kidney. So what's the difference here? Because staghorn, exactly, it's a growing and infectious, so it kills the tissue. That's why we always request DMSA scan in spite of good parenchyma. Good parenchyma doesn't indicate anything. Doesn't mean it's a good function. Obviously, you all know that. So that's why, because it's growing and infectious.
Sorry, I can't interrupt. Is it not to judge its worst treatment or not?
Of course, yeah, that's the next step. So you need to say, well, it's a growing stone and it's infectious stone, so there is a risk of significant deterioration of the kidney function. That's why I need to see the splitting of the function, so I can determine whether to go for nephrectomy versus PCNL. Yeah, that's correct. So can we leave a staghorn stone? The common answer is no, because you can mention Singh and Blandy trial. I wouldn't mention it. It's a very old study, 1975.
Tickman?
Tickman is a very good trial. 177 patient over 177 patient over 77 months, isn't it?
Yes, I remember number 7. Yeah.
But the good thing about the Tickman trial is that the mortality rate is almost 67%, which is crazy, which is good, like to mention it. But now there are other studies, they are all the Subramanian trial, 2015, which showed that you can leave the staghorn stone for 2 years with no treatment, provided that the kidney function is fine, no infection, the other kidney is normal, so you can do that. And it's supported by another study in 2021, remind me, it's called Roberts trial, is it?
Morgan
trial. Yeah, Morgan trial. So you need to know that, Peter, okay?
Yeah, sure.
So remember that
Morgan trial in the notes.
It is. There is another trial in the notes I added recently.
Okay.
I think it's Morgan.
Yeah, 2020 Morgan study.
Yeah. Okay. So who's next?
I can take it.
Okay, of course you can.
Okay.
Intraoperatively, the patient experienced severe bleeding through the sheath. What would you do? Who's taking this?
Yeah, me, Alomari.
Alomari. Okay. So what would you do if he starts bleeding?
So first of all, I will assess how is I will ask them. I will see how is the severity of the bleeding. I will assess the patient stability, talking to the anesthesia, and to see how he's doing. Then, if the bleeding is severe, I will put in mind that the patient may need a blood transfusion. So I will check if the patients have cross match and 2 blood units ready. Then I will start trying to stop the bleeding itself by doing bone compression. And by if it's not stopped, then I will try to do to put a nephrostomy and may defer the procedure and try to do angioembolization. If this does not work, I may at the end the patient may end by nephrectomy in very rare cases.
Very good. A 32-year-old pregnant lady, 27 weeks, with right loin pain. What's your next step?
So the patient with right loin pain in the emergency department?
It's not mentioned.
Okay, so I would like to go and see this patient myself without a delay. If it was in the ward or if it was in the clinic, I will see her with a specialty nurse. I will involve the gynecologist from the beginning to see how is the patient doing and how is the pregnancy is going. I will ask about the loin pain itself, for how long it had been there, the shock rates of the pain, site onset character, and also will ask about the possibility of recurrent UTI and lower urinary tract infection, lower urinary tract symptoms, and the hematuria. We'll ask about the fever. We'll assess the patient, especially from the beginning, to see if she's stable or not. We'll then ask about the past medical, surgical, drug allergy history and previous history of stones and medication that she is taking. Then we'll go to the investigation. I will assess the urea electrolytes and full blood count, urine culture, urine analysis, and I will ask for ultrasound for this lady.
Take me through it.
So this is a grayscale ultrasound. I'm not pretty sure if it's right or left kidney. I can't see. I'm looking from my mobile. Sorry. So this is the right kidney. I can see the liver there. There is multiple hypoechoic areas in the kidney itself, which may represent gas inside or hydronephrosis. There is also some hypoechoic areas inside the kidney itself, which may represent emphysematous pyelonephritis. But I need to see the whole picture and to see the whole images, sorry, to see the bladder and also to talk to the radiologist regarding that.
So how does the gas look like in ultrasound? Does it look black or white?
The gas looks black in the ultrasound. Am I right?
Is it?
I'm not pretty sure, to be honest.
Okay, fine. Okay. What's your diagnosis here? There's hydronephrosis. What is this here, black thing here?
So it can be fluid and calyceal rupture. It can be an abscess.
Very good. Well done. Okay, what's your next step here?
So for this lady, I believe I want to know how is stable is the patient, and I will discuss with the gynae again how she's doing. She's at 27 weeks, so she's in the third trimester now. So I will discuss with her this if the patient is if I'm in doubt of having a stone, I believe I will do on the ultrasound we can see ureteric jet, but I will do an MR urogram with to see if there is any filling defect.
Would you admit her? Would you give her antibiotic? Would you give her IV
because
fluid?
I don't know exactly if the patient is inside or in the clinic, so that's why I don't know.
But would you consider antibiotic?
Yeah, the patient need the patient need antibiotic. The patient need admission.
What antibiotic would you give to a pregnant lady in the third trimester?
So the cephalosporin and the penicillins are usually sensitive. Usually, safe for pregnant ladies. So we can.
What if she's allergic to penicillin?
So then the erythromycin and clarithromycin can be given.
Okay. So this is the MRI scan. What do you think?
Okay, so I can see this is the T2 image for the coronal view of the T2 image. I can see that there is a filling defect in the distal part of the ureter. There is also, I'm not pretty sure if this is a duplicated system. I'm not pretty sure, but I want to see the whole picture, and I want to talk to the radiologist regarding that. I can see other filling defects. There is also hydronephrosis in the kidney itself.
What about the left kidney?
I can't see the left kidney in this, so I want to see the other images.
Why? This is it. It's normal. Okay. So what's your next step, Mr. Al-Omari?
So for this lady with this filling defect, and if the patient is stable and she's not in pain, I believe we can consider the possibility of conservative management. I will talk to her about that. If the patient is unstable or having severe loin pain or having infection or pyelonephritis, I would consider talking to her regarding the possibility of doing JJ stent, but also I will consider talking to the gynecologist again and the anesthesia to have, and I will add the patient to the MDT to be discussed, the MDT stone MDT to be discussed.
So she's in her 24th week. Why do you want
24th or 27th? I'm sorry.
Doesn't matter really. 24, 27, 27, even worse. Like she's almost there. Why do you want to do double J stent? Why don't we go for nephrostomy?
For nephrostomy, she's 24 and.
Like, what's the point of not doing nephrostomy? And before that, so you said managing her conservatively. This is a patient with obstruction. And there's rupture of calyx, most likely.
Yeah, the
because
rupture
there's
of
a
calyx is
collection.
the thing that will defer us from doing the.
Okay, fair enough.
from
So,
inserting-
so you will proceed with intervention. What's so you choose? Okay, you choose stenting, right?
Yeah.
Okay. So, what are the possible complications of nephrostomy tube?
So nephrostomy tube, it's the injury of the bleeding, infection, and the radiation exposure, especially in this case for a pregnant lady.
Yeah.
Also, the inability to reach to the kidney. But there is no hydronephrosis in some patients, and the importance of having a radiologist is one of the problems with the.
What are the metabolic changes that happens to a pregnant lady?
So usually hypercalciuria and proteinuria, and there is also decrease in the pH of the urine. I'm not pretty sure about the last one. But this usually imposed by the other factors that or the inhibitors of growing which is the increase in the urine output and increase in the Mg and the citrate.
Very good, well done. So how do you think you did?
No, I did not did well, to be honest, because I was thinking about the gynae patient. I forget that the patient having rupture first of all. And the gas thing, yes, as you mentioned, the gas will be white when you see it in the ultrasound. This is a rupture of the calyces. I did not figure out what the rupture of the calyces, so I have to see it, to be honest, before that. And for this patient, especially with pain and what we call it, rupture of the calyces, I have to go directly and insert nephrostomy, which would be easier and less incrustation than the stent, and do not have general anesthesia.
But I think you did well, not bad, but you probably will pass, but not with a good mark, I guess. Because your information is very good, but you missed important point, just important point you missed. Like, for example, I wouldn't mention the gas, and you brought yourself, you brought a problem to your scenario when you mentioned gas. If you didn't mention the gas, nobody will ask you about what's the color of the gas anyway.
Yeah, you're right.
But you take me through the image very well, and you're very confident, you're fluent, good speed. You went through the image really good, and then you requested MRU or T2 weighted image. You went through
what's
it very
with the
well.
MRI? It looks like there is two ureters on the left side.
No, I didn't. You were talking about this, right?
Yeah. Like
yeah, I don't know what it is to be fair. It could be.
The kidney, to be honest.
Spinal cord.
Is it?
It could be. I don't know really. I don't. But this is the left kidney. Just focus. Well, yeah, this is the left kidney here. You can see the ureter here. That looks suspicious because it's going down to the bladder as well.
Yeah.
It could be a duplicated system. But yeah, you comment on the right side. But even in the comment of this picture, there wasn't mentioning of any duplicated system on the left side. However, it looks like it. I don't know. But so you commented on the right side. Say that again.
Could it be the fetus? Or
say that I couldn't hear you very well.
Yeah, could it be the fetus, the boy?
This one?
She's pregnant. Yeah, the one in the middle. The marks.
No, this doesn't look like a fetus. No, I don't think. I don't know. I don't think.
Like a spine or whatever.
No. So
why boy? Sorry.
Boy.
So this is a ruptured calyx. Obviously, there's a fluid here, so this is ruptured calyx. You might be prompted. It's not a big deal because it's difficult. We don't really comment much on MRIs. So even if the examiner prompts you, it's not a big deal really. But since there's a fluid, obviously you need to avoid conservative management, and you need to start the patient antibiotic, which you did. Complication of PCNL, easy, not problem. Metabolic change, you mentioned it perfectly. Increasing all the stone formers will be increased in pregnant female, like hypercalciuria, hyperuricuria. But at the same time, this is because of the placenta produces dihydroxycholecalciferol. But at the same time, as you mentioned, there will be increasing the level of citrate. Our protector, stone protector, citrate will make your urine as always alkaline and prevent precipitation of these stones. So you mentioned that correctly. And antibiotic, very well. mentioned. You need to know
Why
all
would
the
you consider antibiotic Rakan in this lady? Is the urine is positive for her?
I would put her on antibiotic regardless because there is a fluid collection after with ruptured calyx. In those cases we do empirical treatment. So once you suspect infection, you don't need to wait for an evidence. That's empirical treatment. It doesn't go against. I know you're concerned about what's the protocol name? What is the UTI protocol recently updated?
Sepsis. No.
No, that's you need to treat with evidence. It's very famous. Like it's recently updated a few months ago.
You mean stewardship?
Yes, yeah, stewardship. Yeah. So it's updated recently. Yeah? They added some stuff 3 months ago. You can go and check it. But it's not so empirical because this is a common debate also. Empirical treatment is not against the antibiotic stewardship. It's not. It's with it.
Actually. And you're going towards conservative in this case, yeah, correct? This is
no,
understanding?
Of course not. Because there is a fluid collection. Since there is rupture of calyx, you can't go conservative. You have to do something. Okay, because there is an obstructed stone, she will keep leaking because the hose is closed. Either you can put a stent if you can do that, with minimal radiation exposure, etc., or you can put, or you can discuss it with the radiology, knowing that it's really challenging because the system is drained, it's collapsed. But you need to do something for this case. You can't leave her without.
I just missed some points. Sorry for that.
Yeah, go ahead.
What if she is in second?
Yeah, of course, definitely. That's the better answer actually. But my question was straightforward. What antibiotic would you offer her? I want to know his knowledge in regard to the antibiotic. But generally speaking, yes, you always involve teams in the exam. The more team you involve, the better mark you get. Involve the mark. So he started by involving the gynae team, the gynae nurse to check the fetus. That's very important. That's more important than your intervention actually for the exam. And then he started to talk about the urology plan. Also, seek medical. Obviously, you need to talk to the microbiology, especially if she's allergic to penicillin. He mentioned clarithromycin and erythromycin, which is safe, obviously. You need to go through the antibiotic that's safe to be given. It's all in the notes. Who's next, guys?
Sorry, Rakan. If this lady in second trimester with ruptured calyx, is it better to do nephrostomy and plan for primary arthroscopy before going to the third trimester, or what do you recommend?
So I wouldn't go for any, I would go for nephrostomy, especially that she's at the end of her. So the fear of incrustation of the nephrostomy because of the hypercalciuria and hyperuricuria and phosphaturia is not really big in this case because she's almost there, like 12 weeks left for her to deliver.
No, I'm saying if she is in second trimester instead of 27, say it is in her 20 week of pregnancy.
Yeah, the guideline, suggests you can go for primary arthroscopy.
But after drainage of the collection.
Of course, you need to deal with the emergence. Yes, of course.
Okay, lovely.
100%. And even if you are going for after you drain the collection or you put in a nephrostomy and the patient is settled and sent home, you bring her back to a very specialized stone team. It's not you who do the procedure. It should be a stone surgeon, endourologist in an experienced center to deal with pregnant females with a stone.
Rakan, if this patient is not having fever or any signs of sepsis or anything, I know that she's having rupture of calyces.
Yeah.
But can we offer her primary arthroscopy from the beginning and insertion of stent at the same time? If she's in that second trimester?
Well, if that's a debatable. The answer is there's no right or wrong. But if she has ruptured calyx, pregnant female, I would just put a nephrostomy and leave. That's my practice.
Thank you.
Because your answer might be correct if you're a neurologist, but for the exam, I would say the safest thing to do is just put a nephrostomy and leave the floor to the endourologist, to specialized or experienced one. Because you won't bring a a 27 pregnant female in your list and to do ureteroscopy as simple? I don't know really, but my answer would be just put a nephrostomy and leave, and later on I can bring her for elective surgery.
I can take the next one.
Because this scenario comes all the time,
Do I need to arrange for frequent change of the nephrostomy if I'm going to leave it until the end of the
100%? And remember,
4 weeks or 6 weeks?
Of course, there is no time frame, but it's not 3 months like normal, because there is high incrustation. Even with because as you know, there's more promoters. And with the nephrostomy, that's important. It's not like in the urine, like in the bladder, that the citrate will work to prevent. No, it's not. And whenever there's a foreign body, it doesn't work like normal. So the promoter will work more on the foreign body. So there will be more phosphaturia attachment, and it will go with the it will form incrustation very quickly.
So for the PCNL bleeding, you mentioned the last question, the first question that you gave me. So how do you usually, is there anything else other than
I think you did mention it perfectly. You did speak with the team, that's very important. And then you assess the bleeding. You did speak with the nurse to order blood, like to make sure that there's group and safe. And then you started to escalate your management. I would first block the sheath to see if that's will clot the bleeder. But you jump to the balloon tamponade, which is fine. And if the balloon tamponade doesn't work, in that case, your approach is very much correct. But I would say I will assess if the patient is stable. I will go for embolization, angio plus minus. If the patient is unstable and I cannot stabilize him, in that case, I will open the patient, explore, and most likely nephrectomy. But you mentioned it correctly. But I always try in pivotal points. I want you to be very definitive with the exam, so he knows that you are a consultant. You know how to manage these cases in a very pivotal points.
Thank you.
Yeah. Yeah, of course, you can do that. Many techniques. You can block the sheath and see if it tamponate itself. You can, but if it's massive bleeding, severe bleeding, and it's not stopping, you need to go through these steps. And again, the scenario is very common. So the examiner wants you to go through these steps. Okay.
I agree with Rakan. I think they want to go through the bleeding, severe bleeding, not the tips and the tricks we do during the PCNL.
Exactly.
So they want, yes.
Yeah. Okay.
I can do the next one.
Okay. Who's that?
Arabiyat.
Okay, Mr. Arabiyat. Wait a second. Let me put a timer for you. Okay, go ahead. So you have a 37-year-old gentleman. So don't look at you can look anyway. Referred to your clinic by the GP due to recurrent UTI and left loin pain. The patient has a KUB. Take me through it.
Okay, so this is plain KUB X-ray. I can see there is a large branching radiopaque calculus filling the renal pelvis. Also, it's extending into multiple calyces on the left side. This is appearance most typical of staghorn stone. There's no visible gas, no surrounding fluid collection. My next steps would be doing, first of all, I need to see this patient, take proper history, see if he has any urinary tract symptoms, previous UTIs, and also if he has any comorbidities, any medications, past surgical history, examination-wise, see if he has any signs of any chronic kidney disease, body mass index, see if also in the history if he's on any blood thinners, and also because I know this is most likely representing a staghorn stone, I will also proceed with a DMSA scan. Bloods-wise, I will need to do, first of all, EGFR, urea electrolytes, and also I will need urine depth culture, pH as well.
Okay, so patient has a recurrent stone. He's a recurrent stone former, had 2 surgeries in the past. flexible ureteroscopy on the right side. This is his DMSA. Can you take me through it?
Okay, so the DMSA, I can see almost symmetrical uptake in both kidneys, which is more on the right kidney. Yeah, so it's almost normal scan. On the left-hand side, there is a CT-KUB in the coronal phase, which is showing both kidneys, which is obviously showing left staghorn stone. The right kidney seems fine. No visible stones. I can't see the ureters. Also, I can't see the bladder. I'll need to see the rest of the scan. Yeah.
The patient underwent PCNL procedure. He's stone-free. What's your next step?
So my next step, I'll need to assess the patient in at least 20 days because I need to make sure that the patient, first of all, depending on my procedure, is it a complete clearance or not? Have I left a stent or not, or any nephrostomy? I'll need to assess the patient again in the clinic. In our trust, we do it with the CT-KUB if there's any concerns, and we assess the symptoms as well. I will take another history examination, and also he will need a metabolic workup because he had a staghorn stone and also previous stones. I will need to discuss, because normally once we do any procedure for any stone, we do a stone analysis. I'll need to discuss this with him, and also to see what his diet, and normally we do a metabolic workup. We'll need to do a urine collection. Normally we do it with 2 urine collection, one of them with HCl, which is for calcium, for oxalate, for citrate, and for phosphate. The other one should be plain. Normally we do it for the pH, for the volume, and for the cysteine, and yeah, I forgot the rest, but yeah.
Okay, what is the definition of cystinuria?
So cystinuria is it's where the so cystinuria, it's I think it's autosomal recessive disorder. Normally it's related to the CLC 3A1 and also CLC 7A9. So it's normally it will lead to let's say defect in the reabsorption of cysteine, orthonine, lysine, and arginine. So the only one that is insoluble is cysteine. This is why it tends to have more stone formation.
Okay, right. What is the management to decrease the risk of cysteine stone formation?
So in those kind of patients, normally they will need to have more fluid intake than usual, normally 3 to 4 liters a day. They will need to have a low sodium diet, potassium citrate, and also we can use the Thiola. I'll need to warn the patient, of course, about the side effects, because 30% of patients may have side effects like GI symptoms, bone marrow suppression. Yeah, I'll need to warn them about this. There is maybe historical data about the ACE inhibitors, but we don't use them in our trust.
What is the normal level of cysteine in our urine?
Cysteine in the urine. I think it's less than 40. To be honest, I forgot.
What about
I think it's less than 40.
Okay, how do you diagnose cystinuria?
How I diagnose cystinuria. So there is a test called Brand's test. Which is cyanide nitroprusside. So normally we the cyanide will be so normally we give this cyanide, which will transfer cysteine to cysteine, which is 50 times more soluble than cysteine, and the nitroprusside will react with the cysteine, and this will give a purple color within 5 to 10 minutes.
That's very good. Okay, just 30 seconds left. So how do you think you did?
I don't know about the values, to be honest. In the urine, and I'm not sure if I say the test correct or not.
No, you did say it correctly. You did very well. It just because you have good knowledge, be careful. Just focus on the question itself.
Okay.
Because you have too much, which is good. So this is so having very good knowledge could kill you or could pass you. You know what I mean?
Mm-hmm.
You could get 888, or you could fail. So you go beyond the question a lot, and you jump to the next question. You don't know what's the next question, so be careful. Okay. But you did everything. You mentioned it correctly. Very well done. So the only thing I would add here, I would look at this is incomplete exposure. So I want to see the rest of the image here. I need to see the other side of the, you didn't mention that, but you need to mention, but it's not a big deal really. And the history, what's the next step? I wouldn't talk about the history here.
Okay.
Due to recurrent, I would say, so in these scenarios, you don't really know whether I need to talk about the history or not. I would say, provided that I took a detailed history and proper examination, I will do blah, blah, blah. If the examiner wants you to talk about this, he will tell me about the history. But don't waste your time in the history if it's not, because we jumped the history with the X-ray.
Okay.
DMSA, you went through it very well. You went through the CT scan perfectly well. And then metabolic evaluation. Yeah, you did mention it correctly. So the question was about the indication. Did you mention the indications?
No, I didn't have. I don't think you asked me the indications.
Okay.
Because I jumped to it. This is one of the things I jumped to, the metabolic evaluation.
Okay, fine. Maybe I didn't. You're correct. So then you jump to the cystinuria, which you mentioned correctly. You mentioned also the gene, which is located either in chromosome number 19 or 2. Very well. That's if you go straight without any, that will give you 8. And then the underlying pathology, you mentioned it very well. And the management, you did talk about the. So for management of any stones, you talk about the diet and fluid and pH. The last thing will be chelating agent for any stones. So diet, you need to decrease the cysteine containing diet, which is mainly animal protein. For fluid, you wake the patient up even from sleep to drink water to make him drink. So you need about 3 to 4 liters per day for cysteine. pH, you decrease the increase the pH, obviously. And the chelating agent, you mentioned thiola. I wouldn't mention thiola because this is generic name. I would say either mercaptopurine or D-penicillamine. D-penicillamine is up to 250, up to 750. The cystinuria, so normally it's less than 20 milligram per day.
Okay.
If we have the disease, we aim for less than 200 only. Yeah, see, it's difficult. It's difficult to treat it, but very well done. Very good pass, really.
Thank you.
Who's next?
Can I can take it on one of the previous scenarios, because I got this question in the exam. You know, the lady who had multiple recurrent UTIs and presented with Staghorn stone.
Yeah.
I'm not sure if I mentioned that before here or not, but the question actually, I was like very happy. It's a good question, and the scenario went from obstructed kidney, and she will require the patient was septic, and she wanted nephrostomy, and he asked me, the radiologist asked you which calyx you want him to put the nephrostomy. I think he was asking about the planning for the PCNL, so if I can use the track. But the shocking question actually was about this patient presented to her GP multiple times with recurrent UTIs, and they just gave her antibiotics, and now she had this Staghorn stone, and she wanted to complain against the GP because they missed the diagnosis of the stone. So what would you do in this case?
Yeah, these are silly questions. I hate these questions. So what did you answer?
Actually, I laughed. Then I told him I will tell her that I can guide her to the PALS team so she can do the complaint, and I cannot comment on the management of the GP, but she can speak to the GP and raise the concerns with them. I don't know if I needed to be involved more or not.
No, I wouldn't do anything different, really. So number one, you need to respect the right of the patient to complain. Number two, you need to respect your colleague. So you don't need to. I would also emphasize that I'm pretty sure that they did their best to manage you. However, you have the right to make a complaint. And I wouldn't do anything further, really. It's just respecting the patient's right to complain, and don't put against your colleague. These are the main ethical points here, I guess. But nothing really more. Anyone have any suggestions, guys?
Just because I know, and I think he wants me to say that recurrent UTI is one of the reasons for the staghorn stone.
Yeah.
I don't know. I don't know if this is like mispractice or do I need to comment or not. I don't know.
No,
sorry
I
to ask you. I
wouldn't.
just
know
want
what
to
you-
know. Sorry, I'm sorry to ask this. I just want to know if he have you managed to pass this station or unfortunately no.
No, I didn't for many other reasons, but I didn't pass.
So he just was adding. He just was adding. I mean that unfortunately for you, but this is just adding some stress for you, basically.
Of course, yeah, definitely. So yeah, these questions are always tough, but I don't think I wouldn't say really anything different from what you said in this scenario. I wouldn't be involved more as a urologist. I wouldn't emphasize that this is a neglect case. I wouldn't do that, obviously. I will leave this to the PAL. I'm not the investigator here.
Okay.
It would be more tricky if the examiner asks you, that the patient asks you, what do you think of this? That would be a bit tricky. But because I'm not in the shoes of the GP, I'm pretty sure that he most likely he did the best to treat you, but I'm not in his shoes to comment on that. But you have the right to complain to the PALS, and I can show you the steps to do that. And I apologize for any negligence or any mistake that happens from any of our team members. Yeah, like just support, sympathy, the right to complain, the right of not to step on your colleagues' foot, stuff like that.
Okay.
But it's
Thank
a
you.
tricky question.
Yeah, it shifts the whole scenario. So you think about PCNL, complications of PCNL, and they take you other way.
But I mean, that would be probably the last question, isn't it?
No, I think it was in the very beginning.
Wow.
After the nephrostomy.
Interesting. Guys, do you want to take 5 minutes break?
Yeah.
Yes, please.
Okay,
Yeah.
let's have 5 minutes break.
Can take it.
Okay, is it Hassan?
Ghassan.
Ghassan. Okay, you have a 30-year-old female present with recurrent bilateral renal stones. She reports a history of fatigue, muscle weakness, and has had multiple episodes of nephrolithiasis since her early 20s. She has no history of UTI or bowel diseases. Her urine pH is persistently above 6 pH. Imaging shows the following. Take me through the imaging.
This is an X-ray. This is an X-ray KUB
showing
multiple calcifications, stroke stones involving both kidneys. And I'm looking at the bladder. I'm not seeing any obvious stones and no obvious stones seen along the course of ureters.
Very good. Okay. Do you think this is a good exposure, or you want the exposure to be more complete?
Yeah, for better exposure and for assessment of the stone burden and anatomical distribution, I will ask for CT-KUB for this patient.
Can you describe the possible metabolic cause of nephrolithiasis in young adults?
Renal tubular acidosis, especially for a patient with persistently high urine pH above 6. The other possibility, especially for a female, is primary hyperparathyroidism. Other rarer causes include sarcoidosis, milk alkali syndrome, patients with dent disease, and so on. But the commonest.
Very good.
Thank you.
Well, given the patient's background and persistent alkalinization of the urine, what's your leading diagnosis?
Renal tubular acidosis type 1.
Can you tell me about it?
This is a condition when the patient has persistent failure to excrete hydrogen ion at the distal collecting system, leading to urine pH always elevated and metabolic acidosis. These patients will have issue of retaining citrate because of the acidosis, ending up with calcium phosphate deposition and calcium phosphate stones.
Oh, that's really good. Wait a second. Okay. So why do patients with distal, okay, how would you manage this patient?
This patient will need to get her urine. Well, we'll give her. We'll need to get more citrate into her urine. We'll give her sodium bicarb or potassium bicarb, but in tablets or solution. I would use the patient to give sodium bicarb. Improve the hydration status. Yeah, we'll give her about 500 milligram tablets of sodium bicarb.
Okay. Would you prefer sodium bicarb or potassium bicarb?
I will prefer sodium bicarb. Potassium bicarb will give her more cramp abdominal pain, and the patient already have hyperkalemia, so I wouldn't give potassium.
Okay, very good. What are the genetic or autoimmune disease associated with RTA?
Can't remember them, to be honest.
So you mentioned she has hyperkalemia?
Hypo, it's supposed to be hypo with type 1.
Yeah, hypo, not hyper, yeah, because you mentioned
Yeah,
hypo.
with
Okay,
type 1 it is hypo. Yeah.
Very good. Okay. Still there's 2 minutes left. So you have a 47-year-old gentleman with intermittent left loin pain. He underwent an ultrasound scan which showed the following. Can you take me through the image?
Let me have a look. This is left loin pain. Right. This looks like a grainy ultrasound scan. There is, this is the left kidney. There is an stone with posterior acoustic shadow. The parenchyma is not really clear.
Okay.
I can't really see much other than it is destroyed kidney with probably renal pelvic stone with central acoustic shadow. We need CT scan for better assessment, CTKB or better assessment.
So that's the CT.
Right. So this is
Don't
CT.
forget the other kidneys and the bladder, okay? Because don't forget that. Okay.
Yes. It's in my mind. So this is a CT scan without contrast of the left kidney, which is showing a renal pelvis stone. Looks like more than 1 centimeter, large one with dilated renal pelvis and a tiny calcification of the parenchyma and the interpolar region. I can't see the ureter or the other kidney or the bladder. So
okay, it's time.
Thanks.
So how do you think you did?
Well, I should I should remember the stones more. I haven't studied them recently, but
I think you did very well.
Thank you.
You did very well, really. So you went through the scan very well. You just missed the exposure, but you did well. You did mention all the possible causes of stones. You went through the diseases briefly, but it was good. And you diagnosed the RTA, and you mentioned the pathology behind it. So I don't think you did anything wrong, really. Very well done. It's just if there's any studies mentioned, probably you would get a very high mark. The genetic and autoimmunity is very common. So the answer is on this slide. I'm going to send it to you. You have it. You have the access to these slides anyway. So Sjogren disease, systemic lupus erythematosus, systemic lupus, sorry, yeah. And mutation. This is similar to the mutation of the gene with cystinuria as well.
Cystinuria.
Yeah, who's next, guys? So that was a good case. This case is usually a small case. It comes with another case.
I can have it.
Yeah, I would go with potassium, really. But it is true that because the reason why I go with potassium is with sodium, 2 molecules of sodium will bring 1 calcium to the urine. So I wouldn't start with sodium. I would always start with potassium. It does cause crampy pain, that's true, but we start with potassium, 10 milliliter TDS. If you say sodium, okay, it's an alternative anyway. Everyone gives it, but you need always to check the urine collection, the sodium, the calcium level in the urine, because you might induce hypercalciuria. It's called the parachuting technique. So sodium brings with it 1 calcium into the urine. Calcium. So that's why, for example, I mentioned this in the big like in the Saturday lecture, that patient on thiazide diuretics, for example, they have hypercalciuria, and you give them thiazide diuretics. After when the patient visits you in a few months, you will see still there's hypercalciuria. So you wonder what's happening with this patient. 3 scenarios: either either the patient is not taking the thiazide diuretics, okay, that's easy, or guys, the thiazide diuretics, the body gets used to thiazide diuretics, so you need to stop it after a while. Like after 6 months or a year, you need to stop the thiazide diuretics for the same period, then you restart it again. It's like
this is for the absorbed hypercalciuria.
Yeah, well, no, not necessarily. Even the renal leak, not the absorptive one. The point is not that. The point is when you give the thiazide diuretics, 3 scenarios comes to you in the exam. Either there is still hypercalciuria. So 3 reasons. Either he's not taking the medication, or the body is used to thiazide, or the third one, the patient is taking salt. So he's bringing calcium into the urine. So that's why they don't like to give sodium bicarb. But very well. Good, Shafiq, very good. Who's next?
I can have it.
I think this is the last one. Okay, let's go from here. Okay, so this is the patient. Fine, let's anyway, this is the last case. So this is CT scan. Can you take me through it?
Me? Okay, I can see a cross section of CT KOP without contrast, revealing left renal pelvic stone about 1.5 centimeter or so, with a tiny calcification or tiny calculus on the mid ball of the left kidney. However, I'd like to review the rest of the images and discuss with the radiology consultant.
Okay, so this any other images you want to see?
Yeah, absolutely. I would like to review the rest of the images and the scout film to check if it is radiopaque or radiolucence. Okay, that's X-ray KOB. I can't see any radio opacity here, so if it's the same patient, will be radiolucent stone.
Okay, very good. What's your next step?
So next step, after taking proper history and the examination, I will check the patient urine depth for pH and the nitrate leukocyte bloods, and check for full blood count, kidney function, and
everything is normal.
What about urate and calcium?
Normal.
Okay. So in that case, check the patient. If he has no pain, I will counsel him for shockwave versus shockwave guided by ultrasound versus primary uteroscopy and stone clearance by flexible uteroscope and laser.
Well, the patient is not interested in surgical procedure at this stage.
In that case, we can counsel him for chemolysis by potassium citrate, as long as the patient is a radiolucent stone, could be consoid with uric acid stone, so can have a transfer chemolysis by potassium citrate.
You mean potassium citrate?
Potassium citrate, yes, chemolysis.
So metabolic evaluation was done to this patient and was found to have hyperuricuria. What is the definition of hyperuricuria and how would you manage it?
Hyperuricuria is more than 200 presence of uric acid more than 200 milligram and per 24-hour urine collection. And
is it 200 or 600 maybe? I think.
I think maybe around 200. I can't remember.
Okay, we'll double check. That's fine.
600. 600. Okay.
600.
Okay, lovely. Thank you. what's the other question? How to manage it?
How would you manage it?
Yeah, absolutely. I will advise the patient for healthy lifestyle, exercise, water hydration, avoid uric acid containing diet like animal protein, and in addition to alkalization of the urine by potassium citrate, 10 milligram, and teaches the patient how to check his urine pH to be around 6.8 to 7.
Okay, that what you're talking about will prevent the precipitation of the crystals. But what about the hyperuricuria? There is a lot of uric acid coming.
I will advise also for allopurinol, 100 milligram. Yeah.
And how does the allopurinol work?
It inhibits xanthine oxidase enzyme, which converts xanthine into uric acid.
Okay, and how would you manage uric acid stones?
Again, after stone clearance, either by lithotripsy or laser shockwave or lithotripsy or chemolysis. We need to followed by metabolic evaluation and prevent stone reaccumulation by hydration, alkalization, and weight reduction, and animal and diet control by and provide the patient with diet dose leaflet of stone diet leaflet.
Okay. Very well. What is the definition of hypercalciuria, and what is the classification and management of it?
Sorry, I can't remember the exact number. I think it's 8, but I'm not sure it is 8 or so, or like that. Hypercalciuria can happen due to absorptive, due to intestinal increase of bowel absorption of vitamin of calcium, or bone resorption due to secondary to hyperparathyroidism, or urine leak by the effect of the proximal convolutional reabsorption of calcium, lead to increase the level of calcium per 24 hours. I think it's 8, but I'm not sure about the number exactly now. Sorry.
Okay. And how would you manage patient with hypercalciuria due to hyperparathyroidism?
So hyperparathyroidism need to be referred for endocrinology for evaluation and help. Might need surgery for his hyperparathyroidism. Yeah.
Okay. Yeah, and the other, if there's, so you mentioned the resorptive hypercalciuria, but there's also the absorptive and the renal
leak.
Renal leak.
Reabsorption, yeah.
Okay, fair enough. How do you think you did?
Yeah, you tell me.
I think you did well. Just the question of this scenario is a bit little bit difficult, like the hypercalciuria definition and management. It's a bit difficult, but you went through it very well. So you started with this CT. You went through it perfectly. You asked for the rest of the image, and you went through this perfectly as well, and you diagnosed the radiolucent stones. And you went through the alkalization process as well. The hyperuricuria. So again, when I asked you about the treatment of hypercalciuria, you need to go through the diet, fluid, collating energy pH. You did, but not in an organized way, but you did. I wouldn't say you didn't really. So I think you managed all. This is a difficult case. It's all about knowledge, really. So it's not something we do always in our clinic. So you went through it perfectly. So that means good. I think we went through all scenarios of stones. The only thing that we didn't go through is the shockwave lithotripsy technique, etc., which you could be asked these questions in the stone as well. But we'll go through it in the technology. It's not a problem. But we covered all the ureteric stone scenarios, almost like most likely. And the staghorn stones, many cases, and pregnant stones, stone in pregnant female, I mean, not pregnant stones. And probably, I'm not sure if we covered bladder stones in the BPH. Did we talk about bladder stones? We can talk about it.
Just a discussion in the group.
Okay, because it comes always in the exam for some reason. We can talk about it next week. Next week we will do emergency with UTI, and it is very likely that we're gonna put more days during the week because we want to repeat again.
Yes,
a lot
please,
of stuff.
Rafan. Yes.
Yes.
Yes, this will be very helpful.
Yeah, don't worry. We will start to grill more. So we will keep our Saturday, Wednesday, obviously, but we might increase one more day. And you don't really need to attend. If you attend, it's fine. If you don't attend, it's fine. But we're gonna repeat some stuff like we're gonna finish the whole stations, obviously, but we need to repeat some stuff.
Because because I haven't done most of the oncology. I haven't done the prostate cancer and the bladder cancer.
Yeah, we'll go through this. Don't worry.
I feel a bit stressed. Thank you.
No, don't be stressed because you know not all of you came at the same time. So some of you came. So we keep repeating. Don't worry. Even if I need to give it to you separately, we'll gather some people and we give it to you. Don't worry. Don't worry about that. Okay.
About the emergency, Rakan, the link you have sent or the drive does have 2 files which both are not opening or not working.
Is it?
For some reason, yeah. The emergency.
That's fine. I'll fix it. Don't worry.
Thank you.
Don't worry about that. Okay. Fine, guys. Go and have some sleep, and I'll see you next week.